So thank you so much for the introduction and the possibility to be here to present pre-hospital near-infrared spectroscopy monitoring. No conflict of interest related to this talk. There is no doubt that to be able to detect brain hypoxia in pre-hospital care would be the holy grail of emergency care of these patients. It would be a fantastic tool to be able to differentiate, for example, between TBI, cerebral infarctions, intoxications, with a simple and non-invasive device. The concept of near-infrared spectroscopy is that we use these sensors that we put on the forehead of the patient, and the sensor is able to, with light, measure or estimate the saturation of oxygen in the mix of arterial and venous blood in an area of the brain, then providing us with a number that we can have on a monitor and perhaps use that number to diagnose something or then tailor our treatment. If we compare this to other means of monitoring brain oxygen that we can use in the neurocritical care unit, so invasive measurements, it's no question that they will never be able to be used in a super emergency setting. But near-infrared spectroscopy could, because of few complications, fast to initiate, offers a global assessment of oxygen in an area of the brain, minimal procedural expertise needed, lower cost, but the caveats would be extracranial noise, quite slow to react to changes in oxygen, and there's a bit of insufficient device standardization. So the devices show things slightly differently. And of course, it's very problematic to be a believer in this technology when you see publications like this. From the Christmas issue, so we all can suspect that there's something fishy going on in this study. Well, of course, the authors measured cerebral oxygenation in fruit and vegetables. So you can see this butternut squash having quite a good oxygen amount in its tissue. It was not only there for the squash, it was also there for zucchini and yam. You can see very normal values, and then compared to the controls, very similar amounts. Of course, I'm sure my hospital lawyers would have been very happy with this because the researchers have taken care to maintain anonymity, so they're adhering to the GDPR principles. How about using this in the intensive care unit? So we used it for the coma care study, a study where we monitored cerebral oxygenation in cardiac arrest patients when they were in the intensive care unit. So we had different physiological targets. We measured with an in-VOS device. We kept the number from the intensivist so it wouldn't influence otherwise the management. And then we looked at various interventions. So for the first 36 hours, we compared a high blood pressure, a high oxygen, a high carbon dioxide, to a lower or standard blood pressure, to a lower oxygen, and to a lower carbon dioxide. And then we looked at what happened to the near-infrared spectroscopy value. So for blood pressure in these out-of-hospital cardiac arrest patients, in blue, the high MAP group, and in red, the low MAP group. And as you can see, no difference at all. Very similar curves, so no change in cerebral oxygenation measured with near-infrared spectroscopy. Then with carbon dioxide, a higher near-infrared spectroscopy RSO2 value with a higher carbon dioxide. Compared to a low carbon dioxide. So perhaps the intervention was doing what we thought it would, so increase vasodilatation and increase cerebral blood flow and increasing the amount of oxygen in the area that was being monitored. Oxygen, same type of finding. So in the high oxygen group, a higher value than in the normal oxygen group. So it appears that near-infrared spectroscopy will pick up some interventions that we can do to increase cerebral blood flow and oxygen content of the blood in the brain. However, then when we looked at whether this RSO2 value associated in any way with the outcome of the patient, measured with cerebral performance category 1 to 2 compared to 3 to 5, as you will see, there was no difference at all. So the poor outcome patients had very similar values to the good outcome patients. Another way of looking at this is looking at how it associated with levels of brain injury. So on the y-axis, you see the level of NSC, neuron-specific NLAs, one marker of injury to the gray matter in the brain. And on the x-axis, the mean RSO2 value over the first 36 hours. In blue are the good outcome patients, and red the poor outcome patients. And as you can see, there's no trend there. You have good outcome patients with high values, and you also have much more good outcome patients with quite low values. So nothing much there to suggest that targeting a higher RSO2 value in these patients would make any difference to either brain injury measured with this biomarker or the outcome of patients. Of course, the question is then, are we too late in the ICU? Should we start already pre-hospitally? And there's researchers from my institution, Associate Professor Jouni Nurmi, who has shown lots of interest in this. And they've done a pilot study, and they're proceeding now with a bigger study. So looking at cerebral oxygenation measured with near-infrared spectroscopy in pre-hospital patients receiving anesthesia for control of the airway. So receiving the regular anesthesia induction pre-hospitally while being monitored with near-infrared spectroscopy. So in this study, published 2 years ago in Acta Anesthesiologica Scandinavica, the authors screened about 128 patients, enrolled 100, out of which 83 were included in the near-infrared spectroscopy group where they had results. So as shown here, there were cases of technical failure. There were cases where not able to get the sensor to adhere to the patient. So overall, 83 patients. And in these 83 patients, they looked at survival, functional outcome, 12-month survival, and also quality of life. So they have quite good data of how well this associated with the outcome of these patients. So what kind of patients were there? So middle-aged, 60-year-old was the average age, both male and female. Here you see the physiological parameters before intubation, so tachycardic patients, fairly stable blood pressure, high respiratory rate, so these were definitely patients with some form of injury, oxygen saturation fairly okay, a low GCS, so 3 to 6, so definitely unconscious patients with a risk of brain injury. Then the causes for being that the patient was sick was out-of-hospital cardiac arrest, neurological suspicions of bleeds, traumatic brain injury, intoxication, stroke, respiratory failure. So a very wide range of different types of patients. So what did the authors find? So over time, over 80 minutes, over the pre-hospital transport period, here's an example of 4 patients who had very marked changes in the RSO2 value over time. So, for example, this patient starts off with 80 and it drops to 40 with the intubation procedure. But then again, some of the other patients, you don't see that much of a change. There's perhaps something happening, but nothing as dramatic as in this patient. Another way of showing this is in this graph here. So here you see the individual patients who had a marked drop in the RSO2 value after anesthesia and after the intubation. So the blue dots is the value before the induction of anesthesia, and the box and the whisker plots are the variability of the values after the induction of anesthesia. So if you and these are individual patients. So overall, the values drop with induction of anesthesia. It's not that marked, the drop, and there's a fair bit of variability in this drop with the procedure. Then the authors looked at whether this, the magnitude of the change in the RSO2 value associates with long-term outcome. So the patients, there were not so many of them who had a drop of more than 50%, cerebral desaturation events, only 4 or 5 patients, and the dark blue are the poor outcome patients, and the green are the good outcome patients. So in this group, there were very few patients who had a good outcome with this marked drop, but nonetheless the difference was not statistically significant. Then if they looked at smaller changes, so drop in 10% or 15%, overall, there was nothing really clear there to suggest that the patients who had these changes would have a difference in their functional outcome at 12 months from the event. So not much there. Of course, this may be limited to to lack of sample size. So the authors, I think, have just about finished a large observational study, including about 1,600 patients, where they've used near-infrared spectroscopy in many more patients to perhaps look at what this value can give us information in these pre-hospital patients. Well, then how about using the near-infrared spectroscopy value RSO2 to say something about cerebral autoregulation? So we did this study where we aimed to put in art lines during CPR. We monitored near-infrared spectroscopy during CPR. We took blood samples and then continued the near-infrared spectroscopy monitoring after CPR in the patient with return of spontaneous circulation. So this is what it looked like. We used this type of a device, put it on the forehead of the patient, aimed to put in art lines, and with that we were able to look at associations between a change in blood pressure and the change in the RSO2 value. So this would be the typical result of one patient. So examples of, for example, one patient whom we could think that has an intact autoregulation. The blue ones are the RSO2 values, and the red ones, red line, are the MAP values. So you can see that there's changes in MAP, but it doesn't do much in terms of a change in RSO2. So based on this, we could think, okay, this patient has intact autoregulation. Then we had other types of patients like this one, where you can see that there's an almost perfect correlation between these two. So when there's a change in MAP, there's a change in RSO2. So in this patient, we could say that probably this patient has disturbed autoregulation. Then if we put this data into the ESICM Plus program that calculates associations between a change in one variable to a change in another variable, you can get something that looks like this. So a box plot with the map areas where there is the least association or correlation between a change in MAP and a change in RSO2. So if there's the least association, we think that we may be on the sort of the autoregulation plateau. We're right in between that small plateau, and perhaps that could be deemed as the optimal map, where there is a bit of leeway up and a leeway down in order to not end up on the steep curve or a part of the autoregulation curve. So perhaps in this patient we could say that based on the pre-hospital information, the target during the next 12 hours could be something around 78. Of course, since the general recommendation for cardiac arrest patients is 65, so there may be a slight difference in this patient compared to what the guidelines would recommend. Whether that would improve the patient's outcome, we don't know. So, conclusions. Pre-hospital near-infrared spectroscopy monitoring, it appears feasible. Some patients, quite a small minority, if you induce anesthesia, have major decreases in RSO2. We are likely to get a number, and we can do certain things to change that number, increasing oxygen, modifying carbon dioxide. But of course, whether that translates into any form of improved outcome is something we do not know at all at the present. So I don't think near-infrared spectroscopy is ready for prime time yet. And the big question is, will it ever be? Will we ever get a number that we can do something meaningful about? And with that, I conclude and happy to discuss this presentation.
Thank you very much.